So I tried to get y'all to tell me something good that happened. I didn't get a lot of response. Somebody got married. That's a huge thing. Anybody else have positive news you want to share? Any breakthroughs studying for perio?
Something.
What's up, Alyssa?
So it's exciting for me because I love food, but for my wedding, I was so stumped trying to find little snacks for the cocktail hour,
Uh-huh.
and we found some. So I'm super excited.
What did you pick?
Well, it's in October 1st. So we're doing sausage balls, apples and caramel, and then like the ham pinwheels. Took me
Sounds
forever to
amazing.
find,
Did you hear my stomach just grumbled listening? I love that. Anybody else want to share? Good news, anything? Okay, so I'm hoping that these PowerPoints don't take the entirety of class today because I'd really like to go over some other concepts, have you ask questions, clarify some things. First, I just want to tell you your quiz this week is over chapters 15 and 16 because we haven't covered 17 yet. And you can do it from home. We're not going to do a Respondus like Zoom proctoring or anything. Try to take the quiz without looking at any of your, what am I trying to say? Like your resources. Just try to take the quiz. It'll help you prepare, okay? So going forward, I uploaded an updated schedule because we got a little bit behind. So what I'm going to do is move some chapters around, and then I'm going to make one chapter a handout only. And I'll just give you the key, what's most important on that handout is what you need to study for that chapter instead of covering it in class. And it's not anything that's board heavy, so it's more for your information to take with you into practice. Do we have any questions to clarify from last week before we start? No? All right, well, let's jump in. Last week, we talked about systemic factors, and now we're talking about local factors. So these are local to the teeth. This is exactly what's happening on the teeth, at any given time. So here's your objectives, not going to read them to you, but, the main thing here, what do you think the point is of all of this? What is every single slide going to say? Local factors do what?
Increase biofilm.
Okay, increased biofilm retention specifically, right? They hold on to plaque biofilm, and they're not main causes. What's the main cause of periodontitis?
How your body reacts to it.
Good, nice. Okay, so plaque biofilm launches a host response, and then, these local factors are basically just holding on as tight as they can. They want to keep that plaque biofilm where they are. So what are some examples of local factors y'all already know about or that we've discussed previously?
Calculus.
Calculus, good. What else?
An overhang.
Overhang, good. Restorations, perfect.
Tooth anatomy.
Anatomy, awesome. Okay, so do y'all remember talking about morphology and anatomic variants in dental anatomy? Yeah, that's going to come in big here. So periodontitis is not just gum disease or disease of the bone. We also have all these other contributing factors that can cause, issues with caries or other diseases in the mouth. So disease sites. This sounds pretty, common sense. What site on the tooth or in the mouth has disease? What are our signs of disease?
Inflammation.
Good. Inflammation. Whoops. I can spell. Inflammation. What else?
Redness, the color.
Good. Good. Color. So erythema. What else?
Shape.
Good. Like shape of the margin and the papilla. Okay. Bleeding. Bleeding on probing or spontaneous bleeding. So all of these things would indicate that a surface has it's a disease site. So local contributing factors are
What
basically
about smell?
What's that?
What about smell?
Smell? Yeah. If it's nup or nug. Have y'all learned to smell perio across the room yet? It's a real nifty skill until you're at a restaurant and you can smell it on your waiter's breath or something. Yeah. My husband gets upset with me. He's like, now I know what perio smells like and I can smell it when I'm at work. Sorry. All right, so local contributing factors, conditions, habits that increase susceptibility to periodontal infection. So the infection already has to be there. These local factors don't cause disease, right? They just kind of lend to the disease process. And this can be on an individual tooth or surface of a tooth, or it can be throughout the mouth. So disease site is an individual tooth or specific surface that is experiencing periodontal disease. What's the difference between periodontal disease and periodontitis? What does periodontal disease include?
Gingivitis and periodontitis.
Good. Gingivitis and periodontitis. Good. So periodontitis, then, what's the differentiator? How do we know it's periodontitis?
It's not reversible.
Good. Non-reversible. We've got that apical migration of the junctional epithelium. And bone destruction. So these are the big things to remember here. Now, these local factors increase susceptibility. That's your second blank there. They increase susceptibility. And they do not cause disease. They're not causative here. So they do not initiate or cause disease. Initiate just means start. This isn't the start of disease. Now on your handout, you'll probably notice that page 1 is like half blank. For some reason, it would not let me move that table up, but it didn't change the page count anyway, so I just left it. All right, so our goal, what are you and I aiming for? Can we eliminate all local contributing factors? I see you shaking your head no. Why not?
I mean, we can't change somebody's tooth shape unless we want to like hurt them.
Good. Okay, so we can't change the morphology of a tooth. We can't change their occlusion, kind of goes along with that. Can we take care of overhanging restorations or crown margins? Nope. So we're limited. We either have to eliminate or minimize the impact, and we're going to talk about how to get into that. So basically, this has to do with biofilm, how close the biofilm is being held to the tissue, and how much biofilm is being retained in an area. So first and foremost, calculus. I love removing calculus. Do y'all feel that way yet? Like when you were on your Typodont and you could get a piece of that calculus off? Feels really good, right? Really good. So what is calculus? It's basically just mineralized bacterial plaque biofilm. Do you remember what we said about how long it takes plaque biofilm to mineralize into calculus?
Minutes.
Well, minutes is colonization of the pellicle, but this mineralization takes like 24 to 48 hours. And this is why we tell patients they have to floss daily to make sure that this plaque biofilm isn't mineralizing into calculus. Once it becomes calculus, they can no longer remove it at home. So remember, calculus is always covered in plaque biofilm. So you can see here along the margin of this tooth that the calculus is actually holding the plaque biofilm closer to the gingiva. So it's extending away from the tooth and being held closer to the soft tissue. This is one of the reasons calculus is bad. The closer the bacteria is to the tissue, the worse it is, right? It's going to cause more issues with the tissue. Now, the surface of calculus deposits is very irregular, and it's got lots of little pits and grooves in it, which is great for bacteria, right? The bacteria can fit down into those little pits and grooves. So calculus is always covered with plaque biofilm. And what does plaque biofilm suspend in it? What is inside of plaque biofilm? What is that made up of?
Bacteria.
Bacteria. Yeah, exactly. Bacteria. So, you know, it's like a thick, sticky environment for that bacteria to hang out and cause issues. It's important to note that bacteria can cause issues on the tooth surface and on the gingival surface, wherever it's at. If it's the sulcular epithelium or the marginal epithelium, it can cause issues wherever it's located. So here's a really good picture of calculus. And this is typical, of what you'll see for prophies. Patients have a lot of calculus on the mandibular anterior incisors, on the lingual surface. Why is that? Why do we see it here?
Because that saliva duct.
Good. So can anybody here gleek? Where you put your tongue to the roof of your mouth and you can shoot saliva from the ducts under your tongue? Everybody try it. Don't aim at your computer though. Look away from your computer screen. You can probably feel the saliva coming out in your mouth, right? So that salivary duct there allows the plaque on the teeth to mineralize quickly. Because remember, saliva has minerals, it's got calcium, phosphate, it's got all kinds of things in it. And this is why patients develop calculus at different rates. It's dependent upon their salivary content. So some patients have saliva that really helps them keep from getting a lot of calculus. And then other patients have a lot of calculus because of their saliva content. So this is a great way to explain to patients, a justification for your education to them. Your saliva, for whatever reason, makes your teeth build up tartar faster. So we say tartar to patients because that's the layman's term. That's what they know. So as we build up calculus in these areas, it forms ledges, we see spicules, we see all the way around the tooth a ring of calculus. It just depends on how long it's been there. Plaque control becomes more difficult. Again, this rough, irregular surface really retains the plaque and the bacteria, and it's harder for you and I to control disease. You can see, even though this picture is blurry, these papillae are not healthy. They've got, an erythematous look. They're kind of bulbous. They're responding to the plaque bacteria on the teeth there, on that calculus. Does anyone just want to like go at this with your ultrasonic right away? That's how I'm feeling. Nasty. All right, so what is calculus made of? There are inorganic and organic compounds. And the reason I put this on your handout, calcium phosphate. Why is that important that it contains calcium phosphate? Where else do we see calcium phosphate?
Is it in your bones?
It's in your bones and your enamel. So it's actually a crystalline form. And it's very similar to the structure of enamel. What does that mean when we have calculus and enamel? It gets interlocked like this. So that calcium phosphate allows calculus to interlock with enamel. The organic compounds, it still has plaque biofilm, living bacteria, dead epithelial cells, dead white blood cells. What kind of white blood cells do you think are dead inside of calculus?
PNMs.
PMNs, yeah. PMNs. Where am I going to write this? I don't know. Dead white blood cells, PMNs. Because they're coming in, they're trying to take care of that acute inflammation. They eat, and then they die. So sometimes calculus is detectable on radiographs. Sometimes, not always. It depends on how calcified a deposit is. And it also depends on the radiographer. You can see here, I don't see any calculus on this surface. Looks nice and smooth to me. But then when we change the angulation a little bit, you can see that deposit. So we can never rely solely on radiographs to tell us whether or not the patient has calculus on their teeth. You have to combine this with a clinical examination. Now, I just want y'all to take a quick look. If this right here is the CEJ, that deposit is probably like 3 to 4 millimeters subgingival. And it is right near the alveolar crest. So that's going to be a difficult deposit to remove for you and I. I'm willing to bet that this was probably a burnished calculus piece that wasn't completely removed. So it got more aggressive and it's harder to remove at that spot. Let's talk about the types of calculus. And this is not on your handout. It's just, a discussion between you and I. Crystalline forms. Hydroxyapatite. Does that sound familiar? It should. That's the crystalline form involved in enamel. So if these are similar, it just goes to show how difficult it's going to be sometimes to differentiate between the two, right? Y'all are brand new. I do not anticipate that you are able to determine the difference between granular calculus and the CEJ, or cementum and granular calculus. There's a lot of, tactile sensitivity to be developed. And there are two main locations. This is on your handout, supragingival and subgingival. Supragingival is always coronal to the gingival margin. This is visible inside the oral cavity. We can look in the patient's mouth and say, oh yeah, they've got supra all over the place. Now, the maxillary posterior facials or buccal, however you like to say it, that's another very common site. Why is that? What do we have up there by the permanent molars?
The parotid duct.
Good, we've got the parotid up there. So we have that parotid papilla constantly dumping saliva into our mouth. So of course the plaque biofilm is going to calcify faster there. Another thing is that a lot of patients don't know how to brush there. They don't have appropriate home care. So if they're not loosening their cheeks and actually angling their toothbrush toward the gum line, you and I are going to see a lot of calculus in that area. Now, subgingival calculus, this is apical to the gingival margin. Usually supragingival calculus extends subgingivally. Remember when we were talking about gingivitis and we have supragingival plaque biofilm, then we have inflammation and that plaque biofilm becomes subgingival. That gingival crevicular fluid in the pocket is working to mineralize that plaque biofilm right away. So that's the normal progression of calculus. Now, if you have no supragingival calculus, but there's sub all over the place, that basically means that somewhere along the way, someone removed the supragingival calculus and not the subgingival calculus. And a lot of times you'll see that when a patient refuses a scaling and root planing, and we just do a prophy. Well, is that patient healthy if they've got subgingival calculus all over their mouth? No, absolutely not. Now we've had healing of the gingival margin around the tooth, but we have subgingival calculus under that margin. The patient can't clean it. It's going to be more painful for them when you and I go to clean it. So there's no benefit to doing a prophy or a gingivitis therapy for a patient who has subgingival calculus in 4 millimeter pockets. It's just not helpful to them. Now, in between the two of these, I like to make notes about marginal calculus. And it's just what it sounds like. It's right at the gingival margin. This is usually what we see in prophies or gingivitis therapies where the calculus is right around the margin, but it's not quite subgingival yet. It's those 4 millimeter pockets that have marginal calculus. Probably don't see it on a radiograph. They probably just missed a couple appointments or something like that. So marginal calculus. So modes of attachment. I put this picture here so that we can review how plaque bacteria attaches to the teeth. Remember, first we have the acquired pellicle. And plaque biofilm forms how? Is it just like all of a sudden there's a bunch of it, or does it form and like build up?
Forms and builds up.
Good. In what?
Is that the cocky and then the negative, gram-negative?
Yeah. In layers, right? So first we have gram-positive cossi, then we have gram-positive rods, then gram-negative cossi, gram-negative rods, spirochetes. So it forms in layers. And it stands to reason that this initial layer is going to be the first to mineralize against the tooth. And that is what's attached to the pellicle. When that initial layer of plaque biofilm mineralizes against the pellicle, we have attachment to the pellicle. And remember, that pellicle is doing a lot of good things for us. We'd rather have it attached to the pellicle than to the tooth itself. This is much easier to remove. You know, it's the most common form of attachment. It's what you'll be seeing most often out in practice. Most often. Now, I don't think the board is going to test you very heavily on modes of attachment for calculus. This is for your knowledge as you're removing calculus. Now, the next example is irregularities in the tooth surface. So if we have cracks in the teeth or openings where the PDL fibers have detached, and these are microscopic, right? These are really tiny, but bacteria can get down in there, and that's how we get attachment of this calculus. So this is very difficult to remove completely, very difficult, because we don't have instruments that can reach into these microscopic areas, especially in grooves of cementum. So if you see a patient with roots of the mandibular anteriors that look like this, and then the crown of the tooth is up here, come on. It's like the waistline that we all want, right? Like a really thin waistline. This is from over instrumentation of those root surfaces here. So back when we had that aggressive, glassy, smooth root surface, if we over instrument those, it's really easy for calculus to build up there. And it's difficult for you and I to reach it. And then last but not least, we have this direct contact to the tooth. So the hydroxyapatite in the enamel and the hydroxyapatite in the calculus are like, hey, this fits, we can all interlock. Now, is this going to be easier or harder to remove than a deposit that's like this on the pellicle? We have interlocked or we have on the pellicle. What's more difficult to remove?
Interlock's more difficult, but it could be
Right.
medium.
Yeah, it can still be, easily removed, but it's more difficult than if it's attached to the pellicle, right? So this is where that instrumentation stroke comes in. We have to snap the piece of calculus off the tooth to break that interlocking relationship. So now does that instrumentation stroke versus an exploratory stroke start to make sense? Where we have to get into place at the base of the pocket and then stroke upward. Yeah. A little bit of preclinic thrown in here for you. You're welcome. I know it's your favorite class. All right. Next, we have morphology. So the anatomic surface features of the teeth. And there are two things in particular here that are really important: developmental grooves and concavities. The developmental grooves are most commonly found on maxillary lateral incisors. There's a lingual groove, and that's what you're seeing in this picture right here. Now, I want you to notice this is a flap. A periodontist did a flap here. We've got alveolar bone, we're looking real healthy. And then all of a sudden, where did that go? Bacteria was allowed to travel via that groove and cause all this bone destruction localized to the lateral incisor. So here's my soapbox moment for today. When y'all are probing, it's really easy to glance over the anteriors because we think there won't be anything wrong with the anteriors. This is a very, very important spot that we have to probe at every appointment. So just make sure you're doing your due diligence with probing. Now, the maxillary first premolar is the only premolar that's bifurcated or has two roots, but they're usually really close together, right? Really close together. And they've got this mesial concavity. Do y'all remember learning about that in dental anatomy, that mesial concavity? So when you're probing or instrumenting or exploring around this area, you really have to keep your adaptation. That, tip or toe third of your instrument has to get right into this little divot where the concavity is. And sometimes that's really difficult to do depending on what instruments you're using. So did somebody have a question? I heard a microphone come on. Good, okay. All right, so here's a really good example. Patients, if we've got this concavity, how are they keeping it clean? They're not. They can't reach that. And this is what I was talking about, you and I, when we instrument, we have to keep that, the very tip of our instrument on the tooth at all times. So this is where our roll comes in handy. We've got lots of ways that we can just kind of roll into those spaces. Do y'all have the periotypodonts that have a missing tooth and one is super erupted? No? Okay. I'll show you. I have one, so I'll show you after the break. All right, next, these aren't as important. You know, I mean, they're on here, but they're very rare. Cervical enamel projection is basically where we have a little bit of extra enamel. And because of the crystalline form of enamel, it's easy for calculus to get, you know, embedded and bacteria to get embedded in there. And then enamel pearl. We went over these briefly before. I left you a little bit of space, I think, on your handout. Where would this be located on a radiograph? Where would you see this?
Would it be on like the facial or the buccal?
Probably, yeah, facial or buccal. It's going to be in one of the furcations, right? And it's also going to be toward the root surface. A lot of times where we see calculus buildup is at the contact area or just below it. So usually calculus is coronal to the CEJ, unless the patient has massive bone loss. And then what do you notice about the shape of this enamel pearl?
It's pretty circular.
It is circular, it's very smooth. It's not going to feel like calculus. It's going to be really smooth. It might be easy to confuse with burnished calculus, but you should be able to see an enamel pearl on a radiograph pretty easily. Malocclusion. So before I got into dentistry, I always thought braces was just to fix the appearance of your smile. And if you didn't have, you know, a gap in your teeth or crooked front teeth, why do you need braces? I was so wrong. Malocclusion actually helps patients hold on to plaque in areas where the teeth are crowded. Where there's spacing, it allows for food impaction. So patients require orthodontia, or we have to increase their recare appointments in order to keep their teeth clean. Next, we have caries. So can you see how irregular that carious lesion is? How do you think it's going to feel if you and I take our Gracie 1-2 and try to get the plaque out of that? What's going to
Be screaming at us.
Yeah, they'd be screaming. As long as that tooth is vital, that's going to hurt, for one. Two, what's going to happen if we use our ultrasonic on this area?
Will it like take it out like and make a hole in the actual tooth?
Yes, exactly. It will cavitate the tooth. It will make a hole. That's what cavitate means. We will literally remove that tooth structure. Now, I also want to point out, what are you seeing here?
Is that demineralization?
It is demineralization. How about here? Can the patient keep this clean?
Is that decay?
It is, yeah. And you can see the shadow of it here. Can the patient clean that? No. Can you and I clean that? Not without them screaming at us, like Callie said. So I just want you to keep in mind, you know, anytime a patient has, this is called gross caries, and I don't mean like, ew, gross. I mean, there's a lot of caries on this patient. This is most likely a methamphetamine user, just based on how much decay they have in this small area. So can you and I effectively clean this patient before they get this decay taken care of? Probably not. Probably not. Okay, so what's going to happen around this crown margin if we take our ultrasonic up in there?
It just causes them a lot of pain.
You're going to cause a lot of pain. You're going to cavitate that tooth. Then we have, we've lost the integrity of this crown, because where should this margin be? Where should the crown margin be?
At the gum line.
At the gum line. Good. And you can see this is inflamed. We're definitely retaining plaque in this area. We've probably got some pretty good pocketing. Now, this carious lesion is helping to keep that bacteria pressed against the tissue. You can see that if it wasn't there, we might not have as many issues with bacteria in that area. Now, do the same bacteria cause, I should say, are caries and periodontal infections caused by the same bacteria? What's the main cause of caries? What kind of bacteria?
Just the gram-negative.
But it's what kind? They're cocci. This is where strep mutans come in. Strep mutans for caries. And when you write the word mutans, it kind of looks like mutant, like X-Men, right? Like mutants. If we have a mutation or a change in the shape. So that's how I remember strep mutans causes caries. Changes the shape of the tooth by causing caries. Now, what is our bacteria for periodontitis? I see it. P. gingivalis, Mr. Perio. So if you get a question on one of my tests or on the national board about which of the following bacteria is not involved in the periodontal process, the answer is usually strep mutans.
Because that's the last step in the, when we go from the gram-negative to the gram-positive. Is that the one you're talking about, the very last one?
It's not. Sorry, what'd you say?
I was gonna say the last one, like the S one. I can see
Strep
it.
mutans?
Yeah,
it's going to help kind of tip that critical pH, because remember, when bacteria eat sugar, they produce acid, and that acid is what tips the critical pH and then creates demineralization and decay. Perfect. Okay. So bacteria in these areas, they've got a nice little cave to hang out in. It's warm in there. They're not being disturbed. So bacteria can really proliferate in these areas. Orthodontic appliances. At least weekly in practice, I had patients ask, can I get my bar removed? They didn't want their lingual bar anymore because they couldn't keep it clean. So what happens when we remove the lingual bar?
The teeth can shift.
The teeth start to shift right away. Those are the thinnest roots in the mouth, so they're the quickest to move. So anytime a patient asks, can I have this removed? We have to tell them, hey, your teeth are going to start moving, and it doesn't take long. So what are our home care recommendations for a lingual bar?
I mean, I guess if they don't want to use a floss threader, you could ask them to use or get them a water pick.
Exactly. Floss threader would be best, but we can ask them to use a water pick in this area. That would have helped a lot for this patient. You can see that when this is the same patient the same day, it's just that we can see these ledges of calculus where the lingual bar was, and the exposure settings were changed. But look how inflamed that tissue is. That's definitely a problem. We know braces, patients, retain plaque on their braces because they don't brush. Plus, it's just hard to brush around braces. So let's talk about dental restorations. Iatrogenic. This is your blank under dental restorations general. Iatrogenic factor. This is some sort of dental treatment that results in an inadvertent adverse outcome. What does this word mean? Inadvertent.
Not purposely or not.
Right. It's like it's on accident, right? Thank you, Ashley. So it's on accident. We didn't mean for that to happen, but it happened, right? So these contribute to inflammation, decay, periodontitis. We see lots of issues with these. The first one we have are overhanging restorations, and it means exactly what it sounds like. There's excessive restorative material hanging over the margin where it should be. What kind of restorative material do you think this happens most commonly with?
Amalgam.
Amalgam, good. Y'all want to hear a funny story? I'm going to tell it either way, but I worked with a front desk. I helped one of my friends get his girlfriend a job at a dentist office I was working at. She's calling, confirming appointments for the next day, and she says, "Hi, Mr. So-and-so. This is Jess. I'm calling to confirm your amalgam for tomorrow." And now every time I hear amalgam, I want to say amalgam because it was just so funny. And I was like, "Jess, it's an amalgam." "No, it says right here, amalgam." She was very adamant. Now she's a nurse, which is a little scary, but we all have our we all have our issues. All right. So amalgams, we often see this with amalgams. What is the easiest way to check for an overhang?
Explore, floss.
Explore, floss that tooth. Dentists should be flossing contact areas to make sure, first, that they have a contact, and second, that there's no overhang in that area. When we see an overhang like this right here, look at the bone loss as compared to the next interproximal area. Every time that patient eats, we're just packing food and plaque down into that embrasure space. So when you and I are exploring, what would you feel with your ODU 1112 right here on 31 distal?
Like a catch?
Yeah, you would catch, or it feels like a click, right? And you can kind of hear the metallic ting when you click on that. So that's a problem that you and I can't take care of, but that needs to be brought to the dentist's attention. Next, we have open margins. It cut off this picture, and I'm really sad about it because it's a great picture. Open margin basically just means there's no contact between a restoration and the adjacent tooth. So we see this a lot of time with crowns, that we don't get that contact back that we needed. This just allows, again, for plaque and food to get trapped in that embrasure space. Bulky crowns. What's going on with the papilla here? Does that look happy? Nope, we have encroached on the embrasure space. We basically took up too much room where that papilla should have been allowed to exist without being encroached upon. Poorly contoured crowns. This is a big one, especially for implants. Can you see that, look at the shape of this crown, right? On the natural tooth with a crown over the top of it versus this. That's just, again, allowing for all of that food and bacteria to get caught down here. Now, what shape are these defects around the implant?
Scooped out, saucered.
Scooped out saucers, good. Where should this bone level be on this implant?
To the highest thread.
Good, to the highest thread. So at least here. That's pretty significant. We've lost about 5 or 6 threads. That's a big problem. Pretty soon that implant's going to be mobile. So this is why we have to put normal shaped crowns on implants. Faulty restorations. Okay, this right here is why I am not a fan of perio splints. Do y'all know what a perio splint is? It's where we take composite. Usually it's on the lower anteriors because those are the first to be mobile during perio. We take composite and we basically glue the anterior teeth to each other to try to stabilize them. Well, that patient already has perio. You think they're gonna floss under that splint we just placed? Probably not. So they come back to their next appointment and it is packed with food and plaque and calculus. Same thing for crowns that are fused to each other. What are we seeing here?
Is it vertical bone loss?
So this just right here, this is actually an open margin around that crown. Can you see how bacteria can just travel right underneath that crown and cause decay? And then can we see the decay? No, it's a porcelain fused to metal crown. We can't see the decay that's underneath the crown. We can probably feel that with our Explorer. But because this is retaining plaque, we've got that vertical bone loss going on here. You were right about that, Callie. There is vertical bone loss. All right. Biologic width. Do y'all remember biologic width? This is kind of a better picture. More, it's at least more to scale, that we have about 1 millimeter of junctional epithelium and about 1 millimeter of connective tissue until we get to the alveolar crest. Now, if we violate that biologic width, what that means is that we have placed some sort of restoration within 2 millimeters of the crestal bone. And remember, we need this 2 millimeter space here to support the gingiva. So we would actively be causing recession. And then if we place a restoration here, we're probably irritating that alveolar bone. So we'd also be causing bone loss. So biologic width, this is more for restorations, but I have seen this covered on the board before, so I wanted to go over it. All right, removable prosthesis. This is like a removable partial denture. I see a couple issues here with this partial. Number one, this tissue is super irritated. We've created a fibroma down there. Number two, it's holding plaque against the tooth in multiple areas, causing decay, causing recession. It could also be causing traumatic recession in this area. Direct damage. So food impaction. I know y'all haven't seen a lot of patients yet, but sometimes you pick a whole Thanksgiving dinner out of people's mouths because they have food impaction. This right here is because these two teeth are not in contact. So that patient, every time they eat, will have to floss or they're going to have bone loss and decay in those areas. This actually pushes the gingiva away from the teeth and makes a pocket. Does this patient look very healthy to begin with? How's that margin looking? Not so hot, right? Do you think they're gonna floss every time they eat? Nope. Next, we have improper use of adjunct aids. This picture right here is where this is why I never, ever, ever recommend toothpicks ever. They have literally lacerated and punched out their incisive papilla there. It is gone. That's disgusting. You can also see they have wear facets on their teeth, so they probably don't need to be chewing on a toothpick. The other thing is that you can actually find splinters from toothpicks in people's gingiva. Oh man. Splinters from toothpicks in the gingiva. That is so gross to have to like go get forceps and pick splinters out of people's gingiva in their sulci.
Does that not hurt them? Like, can they not feel it?
No. They don't even feel it. They're so small, they don't even feel it. And it's disgusting. Ugh. If you use toothpicks, no judgment. Y'all know what you're doing. Most people don't know, right? And then floss. We know we can lacerate papilla with floss, right? Papillae. We can also lacerate gingival margins depending on how aggressive we are. So what you'll start to see is patients who didn't floss all 6 months, all of a sudden flossed, and they've got tons of lacerations in their mouth. Tongue thrust. So we see this a lot in ortho and like open bites. You can see how the patient's tongue is pushing, right? And it's actually flaring the teeth. This can be traumatic. Of course, if we have movement of the teeth that's not supposed to be there, it's traumatic to the periodontium. Mouth breathing. This is actually like a bad thing to say somebody, to like call them a mouth breather. Wasn't that on Stranger Things or something? Calling somebody a mouth breather. Anyway, in Texas, it's an insult to call somebody a mouth breather. So this is inhaling and exhaling primarily through the mouth. Everybody does this while they sleep, right? But it dries out the tissues, which is not great for the periodontium. And then, of course, traumatic toothbrushing. A lot of patients think the harder they brush, the more clean their teeth are, which is not the case. Not the case at all. So we have to identify this, educate the patient, recommend an electronic toothbrush with what kind of bristles?
Soft.
Always soft. I went to Target yesterday. Anybody here love Target? I was there for 2 hours. It was ridiculous. But I was in the toothbrush aisle and I always like to look. This is how nerdy I am. I love teeth. I would say more than half the brushes were medium or hard bristle. So make sure you educate your patients and tell them to seek out soft bristles. Oral piercings. If any of you have an oral piercing, please don't take anything I say personally. Usually, you know, the most common is on the tongue or the lip, but now there's like snake bites and people have got, they're piercing like their frenum, and there's a piercing for the incisive papilla now. Have y'all seen that? I'm like, oh, that would hurt. Like, I don't want that. So what do people with tongue piercings do?
Flick it on their teeth.
They click it. Yeah. What are they clicking against? The gingiva. It's causing recession. They are actually causing recession on their teeth. If, you know, I was a cheerleader in high school. I know you can't believe that, but in high school, we had a stunt camp, and one of the girls in the camp had a tongue ring. And while she was doing stunts, she was closing her tongue ring between her teeth. I was like, you're going to rip that right out. Don't do that. So a lot of trauma, a lot of infection. We actually see teeth fractures from the metal piercings being clicked against the teeth. And then allergic reactions to the metal happen quite a bit. And as y'all know, we always remove oral jewelry before we take panos or, you know, any radiographs if possible. Did you know that there can actually be calculus on tongue piercings? Plaque biofilm will accumulate on a tongue piercing, and then it can become calculus. That's gross. All right, this is, oh, go ahead.
Can that lead to like infection in the bloodstream though, if it's like not healed?
Yeah. Yeah. This is where education comes in for our patients. We have to tell them like, hey, no judgment, cool, love your piercing. Here's how you take care of it. They have to take care of it if they're going to have it, just like any other piercing. So trauma from occlusion, this is really important. This is one of the most important factors here for local factors. We can see direct damage to the periodontium from excessive occlusal forces. Does anyone here have a night guard? I have to wear my night guard every single night or I wake up with a piercing headache. Yeah, I wear my night guard every night. You don't have to be embarrassed. So if you have traumatic occlusion or you're doing things like bruxing, grinding, or clenching your teeth, I clench a lot during the day when I'm thinking. So this is where we see injury to the periodontium. This can be really rapid, and there are a couple different things. We have primary or secondary. Primary trauma is damage to a healthy, intact periodontium. No periodontitis, it's just that the occlusal forces are causing issues with the intact periodontium. Secondary trauma is injury to a reduced periodontium. So this is, injury from normal or excessive occlusal force on a reduced periodontium. What are some clinical signs y'all think we would see for occlusal trauma?
Chip teeth.
Okay. Chips.
Flat occlusal surfaces.
Good. Flat occlusal surfaces like wear facets. Good.
Would attrition be?
Yeah, attrition for sure. How about radiographically? What would you expect to see? Widened PDL radiographically. A widened PDL can indicate that the patient has occlusal trauma. Is that the only thing it indicates? No, but it's definitely something we would see. If we have movement of the tooth within the socket, of course the PDL is going to be inflamed. We might also start to see movement of the teeth, sensitivity, mobility, all of these things we have to check for when we're looking at occlusion. We already went over this, but this is what it looks like when we've got a widened PDL. So during orthodontia, we expect to see a widened PDL because the teeth are moving. We're doing that on purpose. Parafunctional occlusal forces, clenching, bruxism. Usually patients don't know they're doing this. They do it at night. And we recommend a night guard. That's the easiest way to avoid attrition from clenching and bruxing. The last one here, frenal pull. I didn't put this on your handout because we've gone over this before. Of course, if the frenum is tight, it can pull down on the gingival margin, and then we actually get more plaque accumulation where that recession has occurred. We can have a frenectomy. They used to call this a clip, but now we usually use a laser because it's cauterized right away. So you can actually snip that frenum. And that is it. Why don't we take a break before we go over this? Let's take a 5-minute break. So come back at 2:07. I'm gonna pause. So your examination of a patient reveals gingivitis, and in addition, the patient has generalized calculus deposits and numerous restorations with overhangs. What steps might be necessary to bring the gingivitis under control in this patient? What do we need to do to get this patient back to gingival health?
Would we want to take care of the overhangs so that the calculus doesn't get caught to where it's harder for us to get?
Good. So we would need to talk with the doctor about getting the overhangs taken care of. Good. So that would be part of our treatment plan. What else? What are you and I going to do?
Remove the calculus.
Remove the calculus. We have to remove the calculus. We also have to give patient education. If this patient has interproximal calculus and overhangs, what have they been neglecting?
Flossing.
Flossing. So we have to talk to them about the importance of flossing. Definitely a big thing. What toothpaste ingredient would you recommend for this patient?
Stannous fluoride.
Maybe. What's an anti-calculus ingredient? Anybody? Anti-calculus. Pyro. It's pyrophosphate. Anti-calculus toothpaste is pyrophosphate. So that would be your recommendation for this patient. Pyrophosphate toothpaste, like Crest tartar control or Colgate tartar control, whatever it is. Let's do another one. Examination of a patient reveals periodontitis. The patient also has a severe tooth clenching habit. Explain how tooth clenching could be related to the progress of periodontitis. How are these two things related?
Is the pressure causing the PDL to grow?
It's causing the PDL to widen, right? And that's allowing more movement for the tooth. And we don't want that movement. The more movement there is, the easier it's going to be for that bone to resorb, that alveolar bone. So we'd have to get this clenching under control. What are some things we can recommend for clenching?
Mouth guard.
Mouth guard. What else? Massage, right? What are these muscles called? Our major chewers. You all know this. You took anatomy. What are these muscles?
Masseter.
Masseter muscles. Good. So everybody put your hands on your cheeks and then clench down. Feel your masseters? Yeah. So they can massage those. They can do a warm compress to kind of chill those muscles out. Ibuprofen helps, but we'd probably have to figure out what's the root of this problem. Sometimes it's stress. And we've already talked about stress is bad for the immune system too. So addressing their stress. Any questions from chapter 17 before we move on? Okay, let's go to chapter 18. So I know y'all have not had nutrition yet, and some of this is going to be new to you, but I really only included what you absolutely need to know for perio. You'll get a much more in-depth look once you get to nutrition. So if it feels like I'm glancing over things, I am, but you're going to get this again in nutrition. So I'm only relating this back to periodontitis. All right, so obesity and periodontal disease. Do y'all know the like percentage of obesity in the United States?
Is it over 50%?
It's pretty high. Yeah. It's pretty high. Why is that?
Fast food.
Fast food. I went 3 years without McDonald's, and then my husband said he wanted it, and now I've eaten it like 6 times. Terrible. Fast food is terrible, but it tastes so good. All right, so obesity. Basically, this means that a patient is overweight, and there's a BMI, our body mass index. Just use a BMI calculator online. Don't try to do this math. Just use a BMI calculator. Super easy. Google it. It usually pops up. Now, what I want you to know here, the difference between overweight and obese. Overweight is a BMI of 25 to 29.9. Once we get to 30 and above, we're in the obese range. Over 65% of the population are overweight. What does that tell you about patients you're going to be seeing every day?
Possible high cholesterol.
Good, high cholesterol. What else goes along with obesity?
High blood pressure.
Hypertension, good, hypertension, type 2 diabetes. So are we starting to see how what you and I do isn't just about the mouth? We're having to consider the patient's overall health and make their oral health part of that. So if a patient was overweight, let's go with obese. If a patient is obese, what is their ASA classification?
At least a 3.
It's at least a 2. So if y'all look at your clinic manual where it says ASA, I took this straight from your clinic manual, BMI of 30 to 39 is an ASA 2. BMI of 40 plus is an ASA 3. Now, let's say they're obese and they have well-controlled diabetes. Would that change your mind from, if they have a 35 BMI and well-controlled diabetes? Probably push us up to a 3, right? So usually patients who are obese have at least one concurrent disease, one other disease along with being obese, and usually it's diabetes. Adipose tissue, so fat tissue, this secretes immunomodulators, and obese patients have higher levels of TNF alpha and interleukin 6. Do these sound familiar from last week? Host inflammatory response, interleukin, TNF alpha. These biochemical mediators, remember talking about those biochemical mediators? What do they cause? More what?
Inflammation.
Good, inflammation. So biochemical mediators cause higher levels of inflammation in the body. So pretty much any disease that involves inflammation is going to impact the patient's periodontal health. So that's your blank there for periodontitis, cause more inflammation in the body. I didn't go into this a whole lot because I don't think you're going to be asked about it on boards. It's more for your information while you're doing patient education. There are some studies that suggest a link between periodontitis and obesity, which makes sense. They both involve inflammation in the inflammatory response, the host response. So we see more severity of periodontal attachment loss, and we see that those patients are more likely to have periodontal disease. However, the connection is poorly understood. It's not been established. So I would stick with what we already know, inflammation. Now, your book really wanted you to know about these reactive oxygen species. I'm not going to get into this a whole lot. Basically, we need these for cell signaling for chemotaxis. But once they get out of check, once the levels get too high, we see tissue damage. So reactive oxygen species, these are ROS. Does anyone like Princess Bride, or is that movie too old for y'all? Princess Bride, any fans here? I love it. It's one of my favorites. So you know the ROUSs, this is what this made me think of. The ROUSs, rats of unusual size. Those are like the bad guys, right? So reactive oxygen species, same thing. These would be bad. We don't want these. We would need antioxidants to counteract these. So here are some examples. I'm not gonna ask you to memorize these. What's important here is that you and I identify obesity as a risk factor for periodontitis. Patients who are obese, we need to really implement interprofessional care. And that means they need to see their primary care provider. They may need to see an endocrinologist. They probably need nutritional counseling that's outside of our scope. We can give them the information, but we probably have to get involved with other healthcare providers to get this patient the best care possible. Now let's talk about micronutrients. Does anybody here count your macros? That was a big fad diet thing to do for a minute. Count your macros. All right, so
Like
first
Weight
we talked. What's
Oh,
that?
sorry, I was just asking like Weight Watchers, the calculator stuff.
Kinda. Yeah, kinda. And macros are like proteins, fats, carbs. So you would like count how many of these things you had in a day and have to limit it in order to lose weight. Sounds like a lot of work to me. I'm like, no, let's have a protein shake. So first we talk about micronutrients and antioxidants. There are 6 main categories. And again, this isn't nutrition class, so I'm just glancing over. We have vitamins, minerals, proteins, lipids, carbs, and water. Vitamins and minerals, we get these from our food. We can synthesize some of them ourselves in our bodies. Proteins, like chicken, fish, those are good proteins. Lipids are fats, so like bacon. Carbohydrates, what's your favorite carbohydrate? Mine is donuts.
Pizza.
Pizza. I love pizza. What else? Come on.
Potato.
Yeah.
Potatoes. Oh, I love potatoes.
Pasta.
Come on. Pasta. Yeah, definitely.
Bread.
Bread. Chocolate.
Rice.
Everybody? What?
Rice.
Rice. Okay. Yeah, so there's all kinds of carbohydrates. I love donuts. I could eat donuts every single day. So what's the difference here? Micronutrients are usually needed in micrograms or milligrams, not very much. Macronutrients are required in gram quantities. So the micronutrients are vitamins and minerals, and that's what we're going to talk about here. Now, oxidation. Do y'all remember talking about free radicals in radiology? How X radiation produces free radicals inside the body? So oxidation, this is when oxygen interacts with the cell and produces a change. We see these with free radicals. We see this. Have y'all ever done antioxidant treatments for your hair from like environmental pollutants? There are lots of foods to counteract this, but basically we can't avoid damage from free radicals. They are everywhere. They're in the environment. There's nothing we can do about it. Especially if you live in a big city, right, with lots of pollution, you're exposed to this all the time. And we produce them naturally with metabolism. So why is this important to us? PMNs produce those reactive oxygen species in response to plaque biofilm. PMNs are pretty important, right, for the inflammatory response. So when we have a lot of PMNs present, we get a lot of those ROSs, and we're getting some pretty good damage going on. This can also stimulate osteoclast activation. What do osteoclasts do?
Destroy bone.
Destroy the bone. Now, I'm going to be honest, I'm not going to test you guys on this. Your book wants you to know about it, but this is not, in my opinion, it's not researched well enough, and you might cover it in nutrition, but for perio, I don't find it important. Now, this is what's important, antioxidants. If we're creating free radicals and oxidation when we take x-rays, it stands to reason that we would recommend antioxidants. So these counteract the damage of oxidation. We know that a patient's nutrition influences periodontal disease, the onset, the progression. It can have a lot to do with wound healing. And antioxidants are also involved in regulation of the inflammatory response. What did we say happens if we don't have regulation of the inflammatory response? What do we get?
It can overreact.
Good. Overreaction. We see chronic inflammation, which we don't want. So we do need antioxidants in our diets. We can get these from fruits, veggies, nuts, whole grains, legumes. That just means like beans, vitamins, minerals, enzymes, all kinds of stuff. I'm not going to ask you about the sources. I'm going to ask you about this part. Why are antioxidants important in periodontal disease? Because nutrition influences everything about perio. Now, vitamins. Vitamin C is a very, very important portion of perio. Vitamins are basically organic compounds. They're not synthesized by the body, and they're necessary. So vitamin C is also known as ascorbic acid. You can see this referred to either way. And boards really likes to play up on the terms that have alternate names. So vitamin C and ascorbic acid. You don't really need to know about this yet, but later that'll be important in nutrition. You and I cannot synthesize vitamin C. It has to come from our diet. We can't make it in our bodies. We have to consume vitamin C. So fresh fruits, veggies, berries, tomatoes, leafy greens, all that healthy stuff has vitamin C in it. Now, scurvy, this is the vitamin C deficiency. You have to know about this. This can lead to a lot of different things, but what's important for us, poor wound healing. If a patient has perio, we need those wounds to heal, right? Fractures, gingival inflammation, weakened periodontal ligament. We can't get mature collagen fibers to develop. So this would be an issue with what kind of tissue in the oral cavity. Collagen fibers make up what kind of tissue?
Connective tissue.
Good, connective tissue. So remember when we talked about that the epithelium is just a thin layer that's supported by connective tissue that makes it kind of like bouncy? Well, what if that collagen and that connective tissue is mushy? Ew. Think about that in the mouth. That's pretty gross. Vitamin C also enhances neutrophils, monocytes, and natural killer cells. What do monocytes differentiate into?
Macrophages.
Good, macrophages. And when are macrophages present?
After the PMMs.
Good. So chronic inflammation. So you see how it's all kind of coming back. It's all tying in here. We need vitamin C in order to enhance the functions of our immune cells. So I don't know if this is a bad word. I don't want to offend anyone, but have you ever watched a movie with pirates in it and they call them limey, like a limey bastard pirate, right? Scurvy, one way to get rid of scurvy is to suck on citrus fruits. So back when pirating was a big thing, people who were on boats for long periods of time would get scurvy. So they started keeping casks of limes on ships that were crossing the seas, right? They would suck on limes and then go on shore and loot and pillage and, just raid these villages. And they would smell like limes because they were trying to get rid of their scurvy. So that's why we call pirates limey. Fun fact of the day. This is what scurvy can look like, and this isn't a kiddo. So definitely a vitamin C deficiency for this child. I can't tell if it's the flash, but it also looks like we have some hypocalcification, so probably a calcium deficiency as well. Clinical signs, you definitely need to know these for boards and for me. So this is bright red tissue, it's swollen, it's ulcerated, it bleeds spontaneously or very easily. We can have lots of problems with this. Now, vitamin D, I'm not going to cover all of them that were in your book, only the most important ones. Vitamin D, this can be obtained from the diet and synthesized in the body. Where do we get vitamin D from?
Sunshine.
The sun, yeah. So this is why folks in Seattle, for example, have really bad, seasonal depression because it rains all the time. We need vitamin D from the sun to remain healthy. So this enhances calcium and phosphate absorption. You have to know this. You have to know this. Without vitamin D, our body cannot absorb calcium and phosphate. What are calcium and phosphate important for?
Your enamel.
The enamel,
Bone growth.
our bones, yeah. So patients can take all the calcium they want, but if they're not also taking vitamin D, it doesn't matter. This is why a lot of times you'll see calcium supplements have vitamin D included in those big horse pills. We also see anti-inflammatory properties, which is great for the body. And again, promotes differentiation of the monocytes into macrophages. So that's how it helps with immune responses. So anti-inflammatory properties. Calcium, everybody remembers Sunny D commercials where they were like, get your calcium, get your vitamin C, all your vitamins, plus like 2 cups of sugar in Sunny D that's this big. So a lot of times we see calcium fortified drinks like milk, orange juice. We see enriched flour or grains with calcium because we're not getting enough calcium from things we're supposed to eat. And you'll learn in nutrition, it's kind of crazy. The amount of calcium you can get from vegetables is actually a lot better than you can get from dairy. And again, we need calcium for strong bones. What did we say a lot of women experience around the time of menopause that has to do with calcium?
Deficiencies.
Deficiencies leading to
Osteoporosis.
osteoporosis. Good. So if we have calcium deficiencies, we're going to see issues with osteoporosis. Macronutrients, I didn't include this on your handout because it's just not as important as the micronutrients. But, basically we need a well-balanced diet. We need protein. Protein is used for energy if there's no glucose available, so we can use protein. Refined carbohydrates, this, excessive energy intake causes obesity. So basically when we eat, remember that sugars are converted to what? What are we using for energy in our cells?
Carbohydrate.
Carbohydrates broken down into glucose. So glucose is one of the most simple forms of carbohydrates. And this is what our cells are using for energy, for quick energy. So if we're eating too much and we have too much glucose in the body, it goes to be stored as fat. And that's where overweight comes in, obesity comes in. And right back to the beginning of the presentation, we know obesity is a risk factor for periodontitis. This is also an issue with diabetes. This is why we see a lot of patients become resistant to insulin. What is our role in all of this? You're going to learn in nutrition more about the connection between periodontal health and the diet. And you're going to learn about a lot of deficiencies, diseases associated with those. You're going to learn how to give your patients nutritional counseling in relation to caries, and then interprofessional care, again, dietitians, nutritionists, primary care providers, things like that. One thing that this didn't really touch on that I thought was important is patients with eating disorders. Because a lot of times patients with eating disorders have low levels of, the nutrients we need, especially micronutrients. So we can see a lot of issues with the periodontal tissues in eating disorders. So what I want us to do next is, as a group, we're going to look over page 376 and review a dietary analysis. And I don't want to take too long on this because I do want y'all to have time for questions. So go ahead and let's look at your book, and I'm going to share my screen as well. All right, can y'all see that page okay? Yeah. Okay, so this patient, in the morning, she had 2 cups of coffee with 2 packets of sugar, Honey Nut Cheerios cereal, and milk. For a snack, she had a Danish pastry with icing. For lunch, she had a double hamburger with cheese. Why not say a double cheeseburger? Lettuce, tomato, and onion, French fries, and a regular Coke. For her afternoon snack, she had another Coke and a bag of potato chips. For dinner, steak, French fries, a salad with Italian dressing, garlic toast, and water. And then for her nighttime snack, she had ice cream. How's this diet sound to y'all? Good or bad?
Like mine.
Like everyone's during hygiene school, right? So what are you noticing? What are some of the trends you're noticing in this diet?
Sugars and sweet, well, I guess, and then like fried food.
Carbs.
Good. Lots of sugar and lots of carbs. Yeah. How is this for perio? How does this relate back to perio?
It loves it.
Yep. So if we have a lot of sugar, remember the bacteria in our mouths are ingesting the sugar and producing acid. If we have caries, those caries are retaining bacteria and causing more plaque retention. So this is bad for perio as well. What do we see that's healthy in this mix?
The water.
Water, the lettuce and tomato on the cheeseburger, the salad that probably had croutons and that was the least she ate the whole day, a small bowl of salad, right? So we're seeing a lot of issues with this patient's diet. I also see lots of snacking. That's a problem. Lots of exposure to acid throughout the day. Work. Why won't you work? Boo, it's not working. Okay. That's a bummer. I'm gonna try to bring it back up. Hold on just a second. So we would definitely need to do some nutritional counseling with that patient, right? What would y'all recommend? And I know you haven't had nutrition yet, so I'm not at all, no right or wrong answers. Let's just discuss. What would you recommend?
A yogurt after the coffee to neutralize the mouth.
Okay, maybe some yogurt, yeah, to neutralize the coffee.
Less Coke throughout the day.
Less soda, like holy cow. Do y'all call it Coke there? Is that what you call soda? Yeah. So in Michigan, it's pop. In Texas, it's soda. And in Tennessee, it's Coke. It's that way in North Carolina too. Coke. I'll have a Coke. What kind? Coke? I didn't get that at first. All right. Now, let's think of two behaviors that we could modify specifically. So we said drinking less soda. What's our second one?
Well, could you ask her if she sips on her soda or if she drinks it all in one sitting?
Absolutely. Yeah. And remember, it's better to have a soda with a meal and drink it all at once than to sip throughout the day. So absolutely could ask about that. She had like 1 glass of water the whole day. She needs more water for sure. Another thing we could recommend, I noticed that your diet isn't very well balanced. We're really heavy on the carbohydrates and the lipids, but we're missing a lot of those micronutrients with, vegetables, fruits. Where's all that for your snack? Swap your potato chips for some fruit in the afternoon. How do you think patients are going to react to that?
Not too well.
Yep. I have been trying for 20 years to get my mom to stop drinking Coke. My parents each drink like a 12-pack a day. It's ridiculous. Still won't quit. I'm like, whatever, do you, that's fine. Soda is something people are very protective of. So if she has, these issues, what might we need to discuss as far as obesity? If she's obese, what can we recommend?
Going to visit her primary care physician.
Good. Always ask your patients, do you see your physician regularly? Do you get your yearly checkup? What are some things related to periodontitis and her weight? What would we need to know?
Cardiac complications.
Okay, does she have hypertension, right? We're going to take her blood pressure. What if she has perio and you and I can't get it under control? What would we ask? Have you checked?
Is she like an uncontrolled, like doesn't know she has diabetes?
Good. Have you had your glucose checked recently? And we don't have to say, I think you have diabetes. We should probably check your sugar, right? Just say, have you checked your glucose? Have you had your yearly checkup with your doctor? How's your blood pressure? Are you taking any new medicines? Things like that. There are a lot of ways in conversation with our patients that we can ask questions without blatantly asking a question, right? And that's something we develop over time. All right, any questions about the nutrition chapter? No? Very good, very good. I am actually going to pull up a case study. Would y'all like to do a case study together? Does that sound okay? Let's do it. These are actually from student RDH, so I can't share the PowerPoint with you, but we can go over them in class. All right. So we'll probably only make it through one because these are pretty intense. And I have not posted y'all's case study assignments yet because I wanted to get through a couple more things before you look at your case studies, just so you have all the information you need to answer those correctly. So case number 1, we have a 34-year-old African-American male. He is 6'1" and 205 pounds, blood pressure 135/84, pulse 90, respirations 18, temperature 97.6. Stop. Is there anything in the patient profile, just this part, that you're concerned about?
Blood pressure.
Blood pressure. Okay, so it's definitely not normal anymore. Do we have any guesses, any hypotheses about what stage this patient would be in? What's his classification for blood pressure?
Maybe a 2.
I don't know. What do y'all think?
So far, a 2.
All right, we got a couple votes for 2. Anybody else?
Hypertension. What is that?
Hypertension. Definitely hypertension, right? It's definitely high. So we're not in the normal anymore. Are we at a hypertensive crisis level? Not quite there yet. All right. So we're somewhere in the middle. We're out of normal. We're out of elevated. So we're going with stage 1 or 2. That's where we're at right now. Yeah. His medical conditions, he has hypertension. He knows he has hypertension, and his medications, nifedipine. That should send an alarm bell in your head. What do y'all know about nifedipine?
Heart medication.
Okay, it's a heart medication. Is it working for his blood pressure? Doesn't look like it. So we'd want to ask, have you seen your physician about your blood pressure, right? What else about nifedipine specifically? It's one of those 3 that cause
Gingival.
good gingival enlargement or hyperplasia. Okay, so just from this first page, look how much information we got. He definitely has hypertension. We know his medication's not working. He probably has gingival hyperplasia because of the nifedipine. Now, his chief complaint is bleeding gums and appearance of his smile. He occasionally has a poor reaction to citrus or spicy foods, and his last dental visit was 6 months ago. If he has bleeding gums, is a 6-month recare appropriate for him? Probably not. We probably need what?
3 months.
3 months. Due to the bleeding and the fact that he's taking a high-risk drug, nifedipine, for gingival hyperplasia. His social background, he works in a factory, reports a diet high in sugar and saturated fats, works long hours, and stops for fast food on his way home. No history of tobacco use or periodontal treatment. So what does he need based on this?
Maybe a diet change.
Yep, We're gonna have to do nutritional counseling. Oops, I can spell counseling. Okay. Nutritional counseling.
Would
And
environment,
then,
environmental, like with him working in a factory, depending on like what kind of factory it is.
definitely, yeah, we could see some clinical features in his gingiva or his teeth, depending on what kind of factory he works in. Yeah. How about his reaction to citrus or spicy foods? What do y'all think that might be indicating?
Wear of the enamel.
Okay, yeah. Erosion. What else?
Basically, he's
What
not taking his vitamins.
Yeah, maybe he's not taking his vitamins. Think about lesions in the mouth. Think back to oral path.
Like geographic tongue.
Nice, there it is, geographic tongue. So erosion, geotongue. We got something weird going on here if he's having reactions to these kind of foods. Clinical findings. He has generalized 1 to 5 millimeter pockets with 2 to 3 millimeters of hyperplasia. What is that hyperplasia because of? What does it due to?
Medication.
Due to the nifedipine. Good. No attachment loss. What does that mean?
It's not periodontitis, maybe gingivitis.
It cannot be periodontitis. Good. But then up here, it says 1 to 5 millimeter pockets. Well,
Inflammation.
then we have inflammation for sure.
So like pseudo pockets.
Good. Pseudo pockets, exactly right. These are not true pockets. They're due to inflammation or hyperplasia. So here's our intraoral photos. Yes, I know these are 3 different people, but you can only get so far with Google, right? What are y'all noticing in photo number 1?
He's got a sore.
Okay, so some sort of lesion. How would you describe that lesion?
Almost cratered.
Almost what? You broke up there.
Cratered.
Good, cratered or ulcerated, right? What
Irregular.
surface is it on?
Dorsal.
Okay,
Lateral.
dorsal, kind of dorsal lateral area, okay. What's your differential diagnosis? What do you think this could be due to?
A bite.
Probably trauma, like a bite or a burn, or maybe both. He was having pizza, he was hungry. What do you notice about the gingiva in picture number 2?
It's bulbous.
Okay, we got bulbous.
Dark pink.
Okay, it's like a darker pink with some melanin pigmentation throughout there. And then picture number 3. What do you notice about picture number 3?
Is that a geographic tongue?
Yep. Now, how can we tell the difference between geographic tongue and candidiasis on the tongue, like median rhomboid glossitis?
Would you try to wipe it?
Okay, we wiped it, nothing came off. Where would median rhomboid glossitis be located?
The center of the tongue.
Right in the middle, just like the name says, median. It's in the median of the tongue. So because this is on all areas of the tongue, chances are this is not candidiasis. All right, our panoramic. What do you see on the pano? What are you noticing?
Overlap.
Overlap. How's our positioning? How's patient positioning here?
His chin was too far down.
His chin is too low, right? Because we have that smile line. We want it to be a little more flat than that. So I call this the demon clown. when you're looking at a clown and they smile at you, they always look down, right? They tip their chin down and look at their eyes up. And look what happens to the smile. It's exaggerated when they look down, right? I know, creepy. You'll never forget it. Now, when I look at you straight on, it's straight across. And then when I look up, it's too flat or it's pointing downward, right? So just think of a smile on a creepy clown, down versus up, and what happens to that smile line. Good. And we're actually seeing some Fordyce granules over here. It doesn't matter for this case. I just wanted to point it out. These really small radiopaque specks here, those are Fordyce granules. We're running out of time, but maybe next time we can go over some panel landmarks as a good review. What are you noticing about this FMX? First, is it film or digital?
Digital.
Why? Do you see any errors that might help us determine whether it's film or digital?
Is it film and is there like a light? I don't.
Is that what you're talking about? Yeah, this is actually a film set. There are a couple ways we can tell. Number one, look at the space between the teeth. Can a digital bite block fit in that smallest space? Nah. So we're using paper here. So it has to be film because only film is that small, right? The other thing is the errors. It looks like the film was bent to accommodate the size of the patient's mouth. All of them are bent. All right, let's look at question number 1. If his blood pressure is 135/84, what did we say his classification cannot be? So we have, right now, we have a 25% chance of getting this question correct. What can we cross out?
Normal.
Okay, now we have a 33% chance. What else can we cross out?
I wouldn't say it's stage 2.
Okay, why not?
I mean, it's not extremely elevated.
Okay. So is it elevated?
Yes.
But we're kind of out of that elevated category, right?
I mean, he's classified as hypertension, but I mean,
It's got to be stage 1 or stage 2, right? We're just in between which one it is. Yeah. So normal is less than 120/79, 119, I guess. Elevated, 120/129.
Stage 1.
So that puts him at stage 1, right? Stage 1 hypertension.
what stage 2 again?
140 to 1, is it 140?
Yeah, it's
I want to
one.
say it's 140 over 90. All right. According to this patient's periodontal chart, which of the following best describes his periodontal status? What can we cross off? Let's start there. Right now we're at 20% chance.
He's not healthy.
He's not healthy. He's got bleeding. What else? Now we're at a 25% chance.
We said it wasn't periodontitis, right?
Good. So we can cross off necrotizing and plaque-induced periodontitis. Now, do y'all see how we went from a 20% chance, 1 out of 5 of getting this correct? Now you've given yourself a 50% chance. That's a lot better. So start thinking in terms of what can I cross out for the options in this question. So do you think this is more likely to be dental biofilm-induced gingivitis or non-dental biofilm-induced gingivitis?
It's non because couldn't it be from the medication?
Yes, it's because of the nifedipine that it's non-dental biofilm induced. Does that make sense? All right. Question number 3, which of the following best describes the lesion found on the dorsal surface of the tongue? Stop. Let's pretend we don't know the answer yet. What are we crossing off for sure?
Black hairy tongue.
Yep, I didn't see a black hairy tongue anywhere. Now, we're talking about the dorsal surface, not the lateral or the ventral. So what else are we crossing off? I guess we have to.
Geographic.
You want to cross off geographic tongue?
Would it be the traumatic lesion?
Traumatic lesion.
Yeah, the traumatic lesion, because that was on the lateral surface. Okay, so we already talked about this. We know it's geographic tongue. Why?
Because you couldn't wipe it off.
Couldn't wipe it off. And what did he say in his chief complaint? He's sensitive to
Spicy and citrus.
spicy and citrus. Good. So it has to be geographic tongue for this one. Do y'all want to do one more question? All right. Which of the following is the most likely cause for the mild to moderate gingival hyperplasia?
I would say lack of regular dental care could go off because he has been in 6 months.
Okay, good. It said he didn't have very much calculus, if any, right? So let's cross off calculus. Now, his case specifically, would this hyperplasia be due to biofilm or his medication?
Medication.
Medication.
Good. We said he has non-dental biofilm induced gingivitis. Therefore, it has to be his medication, the nifedipine. Okay, so it is 3 o'clock. If y'all would like to go for the day, you are free to go. I'm going to finish going through this case study on the recording in case you want to watch later, okay? Thank y'all for coming. I'll see you Thursday. Don't forget to do your quiz. All right, question 5. All of the following are recommended for this patient except one. Now, when you see these exception questions, what are we 100% going to recommend for this patient?
Scaling and root planing.
Why? Does he have root surfaces exposed if he has no attachment loss? Mm-mm.
We would definitely
But-
do nutritional counseling.
Good. Thank you, Lexi. Nutritional counseling for sure. Okay. A gingivectomy for hyperplasia? Probably. It's not going to go away on its own. We're going to have to take care of that. All right. So now we're left between debridement and root planing. Now, these are essentially the same thing. We're removing all deposits. Periodontal debridement is only on the crowns of the teeth, whereas scaling and root planing would include the root surfaces. He doesn't have any root surfaces exposed. Therefore, we would recommend a periodontal debridement, and the only one we would not recommend is scaling and root planing. Question number 6, which of the following radiographic technique errors can be seen on the maxillary right premolar exposure? Let's look at it. Maxillary right premolar exposure. What are y'all noticing?
Oh, wait, can you repeat the question?
Which of the following radiographic technique errors can be seen on the maxillary right premolar exposure? So for this one, it's the same, whether we're talking about the PA or the bite wing. So what should be present in a premolar exposure?
Isn't it too anterior?
Yeah, why?
Because you're only supposed to have the mesial of the first molar.
In the distal of the canine. So in this PA specifically, we have the distal of the canine, we have the distal of the lateral, and we have the distal of the central incisor. That is way too anterior, which is causing all of these issues. These teeth look distorted and overlapped because we have the film too anterior. Make sense? All right, number 7, panoramic error. What did we say?
Chin too low.
He's a demon clown. Yeah, chin too low. And that's what's causing these issues, right? Now the anteriors are distorted here. We don't have a good, even distribution. We've got a lot of issues. Chin
If
too
the
low.
chin was too high, it would be like an upside down, like a frown, right?
Yeah, it would be like either really flat because you want a little bit of a curve. There's a natural curve in the dentition, but it would be like that, or it would be a negative smile line. Number 8, which of the following restorative materials can be seen on numbers 18 and 19? What do we see on 18 and 19?
Is it amalgam?
Okay, amalgam. Why do you say amalgam?
Because it's more radio opaque.
Good. It's radiopaque. So our options here were composite, gold crowns, gutta percha, and amalgam. We can definitely cross off gutta percha, right? There was no endo on that tooth. So when we go back and look, right away, we know that's metal because of how radiopaque it is. So we cross off composite. Now our choices left are amalgam and a gold crown. How do we know this isn't a crown?
Because it's just an occlusal.
Okay, because it doesn't cover the entire crown of the tooth. The whole thing would be radiopaque if it was a crown. So this is an amalgam. Number 9, which of the following active ingredients in dentifrice would be the best to recommend to this patient? Let's start by talking about what are these for. We just went over pyrophosphate. What is that for?
Tartar control.
Good. For calculus or tartar control. What is sodium citrate for? Do y'all remember?
For citrus.
No, sodium citrate is an actual ingredient like in sensitivity toothpaste. So this is for sensitivity. Carbamide peroxide. Anytime you see peroxide, what is that for?
Whitening.
Okay. And sodium fluoride, what is that for?
Cavities.
Caries, good. Okay, so does this patient have calculus? Nah. probably don't
Minimal.
think. What was his chief complaint?
Sensitivity.
But only to citrus and spicy foods. See, it's tricky there. So he actually does not have sensitivity. So what would be best for him? Whitening or caries prevention?
Caries because of his inflamed gums.
Okay, so he has inflammation, and what did you learn about his diet?
Carbohydrated and sweets.
Good, lots of carbohydrates. So sodium fluoride would be the best option. Now, I want to go back to his chief complaint. He said appearance of his smile. He never said anything about the shade of his teeth. He may not like the appearance of his smile because of the hyperplasia. So if it doesn't specify, right, his, the color of his teeth, we're going to just move forward with that. All right, which of the following would be the best method for debridement of this patient? What can we cross off? He has gingivitis, so we're not going to.
Would it be rubber cut polish?
Yeah, we're definitely not going to rubber cut polish. That's going to irritate the gingiva further. What else? I think you said it, Lexi.
Oh, I said rubber cut polishing.
Okay, good. What else?
And we would probably want to do not hand instrumentation.
Okay, because of the hyperplasia, it might be difficult, right? Now, what do y'all know about air polishers? Have you learned about these yet?
You can't face them towards the gums, can you? You have to face it out, right?
Yeah, so it's probably going to irritate his gingiva. And then what's the powder made of?
Isn't that too abrasive for him?
Yeah, it would be very abrasive. And the powder actually has sodium bicarbonate in it. What was his medical history?
Does it have to do with the hypertension?
Yes, hypertension. We would not use the air polisher for a couple different reasons, right? So the best thing to do here is ultrasonic scalar. If he has 5 mm pockets, we need that lavage. We need that cavitation in those pockets, right? To kill the bacteria. So our best option, are some of them possible? Yes, we could use hand instrumentation, but this asks for the best method, right? All right, that is it for today. Do y'all have any questions that you want to go over?
I did have a question. I don't see the quiz yet. Have you posted that yet? Or
It should have gone at midnight last night.
okay, maybe it's
Double
midnight
check.
tonight then.
Let me check.
Are a lot of the board questions like what's the best answer?
Mm-hmm.
Okay, that's what I figured.
They're very hung up on that. Somebody just submitted it. It has to be open. Let me put it in your week 6 here. I'm going to stop the recording.